using the bioimpedance, and hopefully we'll complete that study in the next year or two. So now what I want to do is to finish off my talk by going to the third class of solutions, if you like, the solutions that have been designed to reduce or improve the metabolic complications that have been associated with peritoneal dialysis and the glucose exposure associated with that. And I'm going to talk about the as yet unpublished, although it has been presented, ESNT study. So this is a study in diabetic patients, and one of the driving factors for this is this observation. This is an observational study done in North America using the DaVita database, showing the relationship between the survival of diabetic patients on peritoneal dialysis according to their achieved HbA1c. And you can see here that once the HbA1c rises above 8, that there is a significant increase in mortality in these patients, with very high mortalities seen in very poor diabetic control. So one of the objectives with diabetics on PD is to try and get adequate blood glucose control, but also, if possible, see if we can also improve some of the other aspects of metabolic syndrome, in particular obesity, and also the abnormal lipid profiles. So I'm going to talk a little bit about the ESNT study. As I say, this is a study undertaken by Baxter. It was presented originally at the EDTA meeting in Paris in May. It's not yet published, but Peter Rutherford, who's the medical director for Baxter in Europe, has kindly lent me these slides to show to you. So there's just to clarify what we mean by Impendia and Eden, this is two very similar studies that have been joined together to try and answer the same question. So in Impendia, what they were doing was looking at the effects of metabolic control of the combination of physionyl, which is the Baxter biocompatible solution, the low GDP solution. It's also a bicarbonate-based solution, and combining that with icodextrin or extranyl in the long exchange, and neutral, which is the amino-based solution. And of course, these two solutions, extranyl and neutral, are glucose-free solutions. So that is compared with a regime which is entirely glucose. In other words, just using dianyl. In the Eden study, which was undertaken in countries that did not have recognition for the use of physionyl, or couldn't have that, then those patients were randomized, instead of to physionyl, they were randomized to dianyl, but also had the extranyl and the neutral components. So the glucose-sparing aspect of the therapy was identical in both of these studies, the only difference being that in the Impendia study, the glucose solution was physionyl, and in the Eden study, the glucose solution was dianyl. So this is a multi-center, prospective, randomized controlled trial, and it's comparing those two different solutions over a period of 6 months. So here we see the total trial numbers. So this is the two trials combined together. There was obviously stratified randomization, and you can see that approximately 124 or 127 patients were randomized according to the two different limbs, and followed up for a 6-month period. The study objectives, as I say, were to look at metabolic control, and the primary endpoint was the HbA1c measured compared at 6 months compared to baseline. They also looked at a number of other secondary objectives. They were particularly looking at the lipid profile. They were looking at nutritional components, evidence of reductions or incidence of severe hypoglycemic effects were an important part of the study. Indeed, they actually looked very carefully at the adverse effects, which I'll come back to in a minute. The other, in the Impendia limb of the study, they also looked at a few extra things. They looked at abdominal fat, and they looked at left ventricular mass. So the primary outcome of the study was a positive one in that the low glucose regime resulted in a better HbA1c. You can see that the drop has been from around about 7.7 down to just over 7 millimoles per litre. So that was perhaps not unsurprising, but nevertheless gratifying to see that the primary endpoint of the study was successful. They also saw significant improvements in the lipid profile. There was a reduction in the serum triglycerides, there was a reduction in the VLDL cholesterol, and also significant improvements in the ApoB lipoproteins. There were no changes in or differences in weight in the study, the BMI, and in the smaller number of patients just in the Impendia study, they did not see significant changes in abdominal fat composition, left ventricular mass, or function. There were, however, differences in the two limbs of the study in terms of the adverse event profile, and this is potentially of some concern. What they found was that in the patients randomized to the low glucose regime, that there were statistically more episodes of complications associated with hypertension or hypertensive encephalopathy. Of the serious adverse events described in the study, 7 of these occurred in the low glucose solution category, whereas only 1 occurred in the glucose solutions. Interestingly, almost all those cases occurred in the Eden component of the Impendia, of the Impendia-Eden study. So in the countries where they were using the dianeal rather than physianeal solutions. The precise explanation for this increase in adverse events, I think, is not yet fully known. I know that the company is undertaking extensive investigations to understand that, and I hope by the time this paper is published, we'll have a much clearer understanding of what that's about. So I'd just like to summarize my talk. I've told you that we now have some pretty good evidence that low GDP solutions, particularly ultra-low GDP solutions, in the form of balanced solution, can prevent these early changes that we observe in the membrane with glucose solutions. That's an encouraging start, and we hope, of course, that will translate into more long-term effects, beneficial effects on membrane function. I think I've also told you that actually achieving less ultrafiltration is not necessarily a bad thing in the early stages of COPD, providing that patients have residual renal function. And that maybe there are some lessons there to be learned in terms of the ultrafiltration targets that we talk about in the early stages of PD when there are good urine volumes. I think it's also, I've shown you that it's possible to devise a low sodium solution that works. Clearly further testing is needed to see what the clinical benefit of this is, and the place for a low sodium solution is clearly not going to be at the beginning of peritoneal dialysis while you've still got good residual renal function, but perhaps later on when residual renal function starts to drop off, then perhaps a middle strength low sodium solution may have a particular role in improving blood pressure control without having the same adverse effects on the membrane. Low glucose regimes certainly seem to have metabolic benefits, in particular associated with HbA1c and lipid management in diabetic patients. But again, we should be very careful to make sure that we don't reduce glucose exposure to the detriment of adequate volume management. So this is clearly a balance, and the patients are allowed to become volume overloaded or encephalopathic is clearly a risk. And the final point I'd want to make is that we still need trials that address more important endpoints. Most of the trials that I've been talking about are still only looking at surrogate outpoints. And this is a real challenge for peritoneal dialysis as a therapy. In order to get sufficient numbers of patients enrolled in studies, you'd almost have to include half the PD population, which is really rather difficult to do. And so there may be other ways we can approach that, and we're looking at and hoping to develop a PDOPS, which might help to answer some of these questions in larger populations. Thank you for your attention.
Thank you, Professor Siemens, for this elegant talk. I think there is time for one question. No? Dr. Magdi, تفضل.
Thanks, Professor Simon, for this nice presentation. Now, there is no ideal solution that keeps the membrane integrity and the better solute removal and the good metabolic effects in the long term. I mean, there is no still now an ideal solution that keeps membrane integrity and the better solute removal and in the long term metabolic effects.
There's no ideal solution, because what of course we really want is an osmotic agent which does not contain glucose but still produces ultrafiltration. I think we're not going to find a solution, an alternative agent which is as cheap as glucose but actually could do that job. So I think we are stuck with glucose to some extent. I think what we're trying to do is to all the time reduce the amount of glucose we need to use and also reduce the glucose degradation products, or there's other toxic factors associated with glucose.
What about the use of amino acids in the solutions? Amino acids.
Amino acids. So amino acids is part of the impendia regime. So you can use amino acid solutions which are glucose-free as part of the regime, but you can't use it for more than one exchange per day. And the reason for that is that if you use amino acid solutions for more than one exchange, then you drive a metabolic acidosis associated with their metabolism. So the safe upper limit of amino acids is one exchange per day. We should also remember that the concentration of amino acids is sufficient or is equivalent to about a low glucose exchange. If you put too high a concentration in, again, you get these metabolic problems. So we can't completely replace it.
Again, in the balance study, the primary endpoint was residual renal function decline. Did the original disease was put in consideration because some patients may lose their residual renal function rapidly or slowly? Was it put in consideration or just taken the change in residual function as an endpoint? I mean, the primary original disease may lose residual function more rapidly than other diseases.
Yes, I mean, I can't give you the exact figures, but at randomization, as you quite rightly say, different types of kidney disease are associated with different rates of loss of residual renal function once you've started peritoneal dialysis, but they were equally balanced in the randomization process. So the cause of the kidney disease was similar in both groups.
Thank you.
No more question? If no, Dr. Salah, tfadl.
Yes, thank you, Simon, for this elegant lecture. I have two questions. Number one, we know that all these new solutions are much more expensive than the traditional one. And do you think these expenses add something to the new solution? And also, they can solve the problem of encapsulating peritonitis and peritonitis, also encapsulating peritoneal sclerosis and incidence of peritonitis in those CABD patients.
So the first question is really a cost-benefit question. What is the benefit of the new solutions outweighing the costs of and particularly if they're already, as I know in Egypt, the solutions are quite expensive compared to other countries. And I think that's a very valid question. And in fact, in my own practice, just to indicate what I've been doing up until recently, I've been using conventional solutions because I would rather spend the money I have to spend on a nurse for looking after the patients and using them for those solutions. I think the balance study is the first study which is beginning to suggest that this might be worth doing. And my understanding actually is that Fresenius are only making these more biocompatible solutions in certain parts of the world. So their costs are being kept down by that. And in a way, one of the ways forward is to try and persuade the dialysis companies just to make the biocompatible solutions. That would hopefully reduce the cost. Do I think the cost benefit is the same for every solution? Probably not, but I think icodextrin, I think the evidence is strong in so many areas in terms of diabetic control, but also ultrafiltration, membrane preservation. I personally think that probably it is worth paying an extra premium for the icodextrin. But otherwise, I think there's an issue there. And I personally would recommend many units to concentrate more on how use their money to look after the patients with better nursing. In terms of your question about EPS, do I think these solutions are going to prevent people getting EPS? The answer to that is I don't know, because it's a very, very difficult study to do. You have to have thousands of patients on PD for a long time before you start seeing enough cases. So we'll never see a randomized controlled trial that shows that. I think the approach to that is a different one. What we're doing there is to try and understand better the risks associated with EPS, particularly the comparative or relative risks. So for many patients on PD, even after 5 years of PD, they're still much more likely to die of their comorbidity than they are to get EPS. So we're currently developing a competitive risk model for EPS, where we hope we'll be able to say to clinicians, patients been on PD 5 years, actually their risk is this, and compared to, say, dying or transferring for other technique failure, it's still a low risk or it's a relatively high risk. And we're making some progress with that modeling.
Thank you, Professor Simmons, for this elegant talk. Thank you for all. And the noon session will be started after 20 minutes. Thank you.